So thank you for joining us. For the past 3 years or so, the Senior Friendly Hospital Action Collaborative, a collaborative of 87 hospitals across the province, coordinated by this office at the RGP of Toronto, has been implementing quality improvement projects for the care of older adults. And about 40 of these projects have involved hospitals implementing large-scale delirium screening. So I'm very excited about that, and I noticed many of you have signed in, and kudos to all of you for the work that you've done and continue to do. Of course, our office wants to give you more than kudos. We want to share with you the latest and greatest in research to help you be successful in your work. And we're very lucky today to have Dr. Niamh O'Regan join us. She's a consultant geriatrician and clinician researcher at Western University here in London, Ontario. Dr. O'Regan graduated from University College Dublin Medical School in 2003 and also did her postgraduate specialty training in Ireland. Now here's the kicker. She completed her PhD examining early indicators of delirium in older medical inpatients through the University College Cork in 2016 and continues to work in the area of delirium, being particularly interested in finding ways to implement research findings into clinical practice. So a very relevant topic for our collaborative and for all of you here. I will now turn things over to Dr. O'Regan. Dr. O'Regan, if you could unmute yourself and take the con, the show is yours.
Thanks very much, Ken, for that very, very kind introduction. And I'm delighted to see that so many people are tuning in. It's a little bit nerve-wracking though, because this is my first webinar, so be gentle with me. So I'm going to talk, as Ken mentioned, about delirium screening. And I'm just going to share some of my thoughts about how we can actually improve the implementation of screening in our clinical sector. I've gone the wrong way, sorry. So firstly, I have no conflicts of interest, and secondly, which is even one of the major reasons why I actually got invited to do this webinar, I just want to share with you and ensure you're all aware about World Delirium Awareness Day, which is occurring tomorrow. It's the second annual World Delirium Awareness Day, and it's primarily a social media campaign for the advocacy of delirium awareness, trying to improve awareness of delirium among health care professionals, the general public, as well as policymakers. And what we're really hoping is that you can engage with our Twitter feed, follow, tag, tweet, and retweet on @idelirium_aware. And if you do actually have any events planned for tomorrow, what we'd really appreciate is if you could actually tweet those with the hashtag WDAD2018 and the hashtag, which is specifically for Canada, hashtag #DeliriumA. And there are some competitions on our iDelirium website, which is idelirium.org, for the best memes and the best artwork and kind of winning stories. So really hope that you can engage with this and help make World Delirium Awareness Day a fantastic success for this year. So in the next 45 minutes or so, I'm hoping to speak to you about the problem of delirium, what is it about delirium that makes it such a problem, and why we need to actually actively screen for it, and why there's such a gap between what we find in research and what we're actually managing to achieve in clinical practice, and how we can try to address that. And is there any research out there that has actually measured the feasibility of the instruments that we use, and going forward how we can actually measure that. And I'm just going to share some of my thoughts as well as to how, what the characteristics of a screening instrument that's feasible for use in a clinical setting, what those characteristics actually might be. So firstly, the delirium problem. So firstly, it's an extremely common issue, as we're all aware. It occurs in at least 1 in 5 hospital inpatients, with much higher rates in more vulnerable groups, such as older patients, intensive care patients, and the terminally ill. It's also extremely prevalent in long-term care patients, so it's not just an issue in the acute sector. It crosses different clinical areas. It's extremely serious, leading to an extra 10 days on average in hospital, double the healthcare costs, increased risk of falls in hospital and post-discharge, as well as an 8-fold risk of dementia at follow-up. It doubles the need for nursing home placement following discharge, And more concerning, it increases mortality with an additional, an increase in mortality of 11% for each additional 48 hours of delirium. It's actually missed an awful lot of the time, as we're aware, and in our hospital setting across, if we look at different cohorts where this has been measured, it's somewhere about 2/3 of patients are actually missed, which is astounding really when you think about it. Like, we're all aware, we all work in this area, and so we know the statistic, but if you put it in context with other illnesses, this is amazing that we're still missing it this amount at the time. And this is serious because missed delirium actually worsens the outcomes for patients. So, as I mentioned, an 11% increase in mortality with every 48 hours of undetected delirium. But also, one study looking at patients discharged from the emergency department, there was twice the risk of mortality at 6 months of patients who had delirium that was undetected versus those where the delirium was detected. And that was 3 times the mortality in patients who did not have delirium and were discharged. This is older patients. So the delirium problem, in summary, is extremely common, so we need to be able to prevent it, and we do know that about half of it is preventable, but I'm not going to talk specifically about that today. It's really serious, so we need to find out how to treat it effectively. We still don't know what's the best. We don't have any medicines that actually treat it effectively, and we miss it an awful lot. So we need to find accurate ways to detect it and detect it early. So as I mentioned, we don't tend to miss myocardial infarction, for example. Only about 5% of MIs are silent. So why do we miss delirium? Well, firstly, not to say the cardiology is simple or anything. I'd never say anything like that. But delirium specifically is a very complex problem. And this slide, which is borrowed from Jose Maldonado's paper in 2013, which attempted to describe and draw the neurobiology of delirium. And it just shows how complex the different neurotransmitter pathways and different stresses to the brain interplay. And we still don't really know exactly what's causing delirium. And we're increasingly beginning to understand that every delirium case is really unique with a different set of issues that lead to a final common pathway. But additionally, when it comes to delirium diagnosis, there are several barriers. And these barriers include the actual nature of delirium itself. For example, the fluctuating nature where it varies throughout the day and can trick you during a lucid interval, for example. The hypoactive profile that's so subtle and nuanced, it can be very challenging to detect, particularly when that patient doesn't present with active features. And in the acute setting, differentiating delirium from dementia when you don't necessarily know the baseline of the patient can be really challenging. That, together with communication barriers such as language barriers, hearing impairment, and dysphagia potentially from previous stroke disease, can really impact on ability to diagnose delirium. Then when it comes to staff training, at undergraduate level, delirium is still kind of a poor relation and does not necessarily get the focus that it deserves. And this leads to poor understanding of what delirium actually is. And sometimes we have screening tools being used potentially not at the most sufficient or adequate way. And then we look at staff factors such as, burden of care. So staff are already extremely busy and we're asking them to do something else, putting constraints on their time, adding workload and documentation. So this is another barrier to trying to actually implement something meaningfully. And also important is that delirium is an orphan condition. It really sits between psychiatry and medicine, and often ownership is not taken on board. And so it can end up falling between 2 stools, and often depending on who you're working with, but there can be a lack of physician support and physician leadership in trying to identify delirium. So this is why we have to be proactive and actually screen for delirium in all our at-risk patients. And so now a 2-step screening approach has been widely recommended across several different groups, including the National Institute for Health and Care Excellence, which was initially published in 2010, but additionally in our own Canadian guidelines for seniors' mental health in 2006. What does that actually mean? So 2 steps. Step 1 means that you're going to screen at-risk patients to try to identify patients who more than likely have the disease. Step 2 means a more in-depth assessment of those who screen positive. And basically, this is where the waters get muddied. What's a screening test and what's a diagnostic test? So screening is really trying to look at a large group of people and identify those who are most likely to have a condition, whereas diagnostic test is trying to figure out with certainty whether or not a patient has a condition. So in Ontario, just coming back to what we're doing here in Ontario, in senior-friendly hospitals, as Ken mentioned, this framework was launched in 2011 by the RGPs and LINs in Ontario. And an initial environmental scan identified 3 priority areas for action, and delirium being one of these areas. He mentioned as well that this SFH Action Accelerating Change Together in Ontario program identified learning needs that were important for QI success, and now this delirium is the kind of the biggest group of QI projects that are so most of the hospitals are incorporating delirium QI projects. And so what the mandate is from senior-friendly hospitals is to try to implement interprofessional delirium screening, prevention and management protocols across hospital departments to optimize cognitive function. And when it comes to screening, part of that mandate is to implement daily screening in at-risk patients. This is where it gets challenging, because which test should we use? Recently, there's been 2 systematic reviews of delirium tools. I won't say screening tools, because they're not all screening tools. But most of these instruments were not designed nor validated for daily screening by ward staff in a busy acute setting. And we're getting back to this challenging kind of concept of screening test versus diagnostic test. The confusion assessment method, which is a fantastic diagnostic tool, is the most widely used instrument in both clinical and in research settings. It's the most adapted to different languages, different settings, for example, intensive care, the emergency department, using different modes. For example, there's a telephone version, and users, there's a family version for a collateral informant. It's also extremely accurate when it's used by the right person in the right place. And it is, we've recommended in Canada for screening because it's got the most evidence behind it. So if we just step back to when the CAM was originally actually developed, and this was in 1990 by Sharon Inouye, who's the lead. She's basically, the most eminent delirium researcher in the world, and continues to publish very frequently in delirium. And the CAM was based on the DSM-3R, which is the Diagnostic and Statistical Manual for Disease, 3rd revised edition. And it was labeled as a diagnostic algorithm. It incorporated the short diagnostic version, incorporated 4 features: acute onset and fluctuating course, inattention, disorganized thinking, and altered level of alertness, with delirium being diagnosed in the presence of feature 1 and 2, plus 3 or 4. There's a CAM-sensitive version in which feature 1 can be an acute onset or fluctuating course in order to try to reduce the number of missed cases. And that's been used in recent years. In this initial validation study, the sensitivities and specificities were really high, above 90, as well as very high positive and negative predictive values. However, when we actually look at what they did, the ease of use, which is published in the paper, states that the standardized interviews, including cognitive testing, were administered by geriatricians and took a mean of 20 minutes, but were well tolerated by patients. So 20 minutes is a long time. Nowadays, with more use and I suppose more methods to actually try to speed up using the test, it's now quoted as taking about 5 minutes. So the CAM was originally validated as a diagnostic test. However, we're trying to use it as a screening test. And challenges when we try to use the CAM as a screening test include that the sensitivity is low when people are minimally trained, and can be low as 50%. And the sensitivity can also be low if you don't actually anchor the ratings using a formal cognitive test, like the MMSE or some other cognitive test. Specificity is low, i.e. there's too many false positives when there are high rates of dementia or psychiatric diagnoses, for example, in long-term care settings. And as I mentioned, it now takes about 5 minutes, which is fantastic if you're using it as a diagnostic test, but not so good if you're assessing every patient on your ward every day using this test. Additionally, using the CAM, you still need to know the patient's baseline state to actually be able to accurately score it. So as a daily screening tool by routine ward staff in a busy clinical setting where they have competing demands, it may not be the best test. So what we need to try to do is balance diagnostic accuracy with the feasibility to implement something clinically on our wards. And so just going back to one of those systematic reviews that I mentioned briefly earlier, and this was published only a couple of years ago by Van Veltenhuizen et al. And this looked at the psychometric properties and feasibility of instruments for the detection of delirium in older hospitalized patients. They identified 43 studies and 28 instruments, but only 10 of those instruments were actually designed for screening purposes. Only 5 were evaluated in 3 or more studies, and 6 instruments were evaluated in 7 studies in which the instruments were applied by staff nurses. The diagnostic accuracy was poor for some instruments, for example, as low as 36%. But although feasibility is in the title of this study, of this paper, it was examined very superficially. And it was based on the number of test items, the duration of the test, which is available for 18 instruments and varied from 20 seconds to about 15 minutes, the cost, which was reported for 21 instruments, all of which were free, and whether or not training was needed, which was reported for all tests. And only 7 of those instruments did not require training. So in reality, the studies of feasibility really haven't been done. Feasibility also includes other measures such as acceptability to staff and adherence by staff to using the tool, patient and caregiver acceptability, refusal and withdrawal rates, test psychometrics in the real world, not conducted by a research assistant, but conducted by our real-world staff who are busy. Real-world reliability and validity as well. So now I'm just going to take a closer look at 3 studies that evaluated elements pertaining to feasibility and what they actually examined. And these tests were the Niamh, the Delirium Observation Screening Scale, a modified CAM for the emergency department, and the radar, which is recognizing acute delirium as part of your routine. And these were all assessed in this actual systematic review that I mentioned. So the first study looked at both the Niamh Confusion Scale and the Delirium Observation Screening Scale, and this is a Dutch study published in 2007. And there's a typo here, I'm sorry. There was 87 patients included, older medical and surgical inpatients, but actually 9 were delirious, so they weren't all not delirious. 39 nurses completed an ease of use questionnaire, and then they also measured the time to complete the test. And when you look at the ease of use for both tests, we find that the Niamh was less easy to use by the nursing staff, or rated less easy to use by the nursing staff than the DOS. And this was statistically significant for issues like where they felt the language was compatible with the language they use in practice, whether there was a clear difference between the possible answers, that they were able to quickly make a choice between the possible answers, and that they didn't need to request help. In particular, when it came to the final 2, finding it particularly handy or practical to use, or that it offered added value to their practice, the Niamh scored very poorly, whereas the DOS scored very highly. And the mean time to complete the test, the Niamh was 8 minutes and the DOS was 5 minutes, so still probably too long, really, if you're going to consider doing this test on a daily basis. The next study then is a study by Grossman et al. And this looked at a modified version of the CAM in the emergency department, but they used an actual two-step approach. So they trained emergency department nurses to use the months of the year backwards to evaluate attention, followed by this modified version of the CAM if they screened positive. They measured feasibility by assessing adherence, so that was based on completion of documentation, and that was about 3/4. As well as correct use, which is measured only by the researchers actually looking at the completed forms to see if they felt that they had been filled in appropriately. Problems with this was that this assessment of feasibility was conducted only over 1 week, which is not realistic when you consider that obviously there's going to be good staff engagement initially. What they needed to really do is measure the feasibility after a bedding in period. Correct use was not actually monitored, so although they measured correct use by looking at the forms, they didn't actually look and see whether or not they had filled the form out properly based on the clinical status of the patient. And the sensitivity of the test was actually poor. It wasn't powered appropriately for this, and the reference standard was not necessarily diagnostic. It was just based on emergency physician impression without any structured delirium assessment. So then the last study is recognizing acute delirium as part of your routine, which is radar. And this instrument was developed in Montreal by Philippe Voyer and his colleagues. He's a professor of nursing who developed this instrument specifically to help try to address implementation issues. What he was trying to specifically address were issues relating to the time constraints of using tests. So he wanted this to be brief and integrated into routine care. He was also trying to augment user confidence by conducting a training that took about 45 minutes. Patient and nurse acceptability was measured, as well as he also wanted to take out that need for the knowledge of baseline function so that collateral history would not be necessary to actually score the test. And he was also trying to address some elements relating to generalizability and validity by conducting this study in both acute care and long-term care. About 142 patients were included, 23 with delirium, and 139 nurses and nursing students were included, about 100 of whom completed the questionnaire at the end. So this is the radar, and it's a really interesting tool. It's based only on observation, and basically it was validated for use during the medication rounds. So while giving the patient their medications, the nurse would assess to say, did they feel the patient was drowsy, did they have problems following their instructions, and were the patient's movements slowed down? And they'd answer yes or no to this at the time points during the day at which the patient was receiving their medications. Any yes answer was positive and would mean that this person had screened positive for delirium. The mean completion time is highly impressive at 7.2 seconds. Like, this is now in the realm of something that might actually be feasible for practice. The percentage agreement between research assistant and nurse was also very high, and however, the test accuracy was really dependent on the number of radar assessments throughout the day. So as you can imagine, some patients were on medications only once per day, and others were on medications 3 to 4 times a day. But even in those patients who were getting 3 or 4 assessments per day, the sensitivity was still only 73%, which is really not optimal, because in delirium, what we're trying to get is a tool that's highly sensitive to avoid the hazards of missed cases. And specificity, although important, is not as important as sensitivity. So this is an issue with this test, is the sensitivity is not adequate. When it comes to the feasibility and acceptability of radar by nursing staff, this is, again, stellar performance, with the nurses, practically all of them, rating it very highly in terms of ease of comprehension, easy to do during the medication distribution process, that this was an appropriate time to do it, that they felt they'd been trained well, and that it didn't increase their workload. And the training time was, as I mentioned, 45 minutes, but this included a 15-minute PowerPoint with really good videos trying to show the differences between the different elements on the radar, and then practice completing the radar with the training, with the trainer. So in summary, we have many great, in summary so far, we have many great instruments out there to detect delirium, 28 identified in that systematic review, but delirium still is under-detected, so there is a mismatch between research and clinical application. And what I really believe is that the research on feasibility of implementation of screening has not been conducted. So just quickly talk about what I think is important for a test to be feasible and usable in the clinical setting. As I mentioned, it's really important that the test is highly sensitive, that you're not going to miss delirium. It must also be reasonably specific, though, in order to reduce the potential for unnecessary further testing. Like, you don't want everybody to be screening positive. You want to be able to rule out some people. It needs to be short. It needs to be simple. It needs to require minimal training so that nurses can be trained at orientation very briefly. And it also has to have buy-in from the staff on the ward, that they're going to believe in the test, that it's actually going to do something to change care for patients. So what about a cognitive vital sign? And this concept has been mentioned in the literature a bit over the past decade. And like when we think about it, why are we not doing a vital sign for the brain? We do one for the heart, lungs, we check urine output for kidneys. We're checking vital signs on people every day, but we're not actually assessing the brain. Now, some people are, in some settings, certainly in our elderly care wards, we're doing orientation. But orientation is only abnormal in delirium about 70% of the time. Attention, on the other hand, inattention is mandatory for diagnosis of delirium and can be measured quickly at the bedside. But which tests can we actually use? And in 2014, Zoe Teague and her colleagues conducted a narrative review of assessment of attention in delirium. And this looked at 15 different studies and 9 different tests. However, a lot of the tests at that point in time were using pen and paper and took a bit longer than they should take. And some of these tests were dependent on education, or at least were sensitive to education, like DigiSpan, for example, as well as using a computerized device, which is the Dell box, which is used by a group of researchers in Edinburgh to measure attention span. And what they kind of concluded was that although attention is promising, it does need further study. And actually, this, as I mentioned, this review was published in 2014. There's been a lot of studies done since then, which I'm going to talk about. So the month of the year backwards is an attention test, and it had been used clinically without evidence because anecdotally people felt that this was a good test. It was considered to be short, simple, less culturally and education biased. As you can imagine, most people would know the months of the year backwards. You don't need to have high school or college education, and most people around the world would know the months of the year backwards, and certainly in the Western world. There's no need for a pen and paper. You can actually just ask the patient to do this while you're assessing them clinically. So we conducted a study of several different tests, potential screening tests for delirium, and this was published in JNNP in 2014. And what we did was we looked at 265 hospitalized patients ranging in age from 17 to 92. And we conducted screening tests. So we had first and second year residents conducting screening tests using month of the year backwards, spatial span forwards, which is a visual version of the DigiSpan. And we also assessed for objective and subjective confusion by asking the patients, did they feel confused, and asking the nursing staff, did they think they were confused today. And we compared this with DSM-4 diagnosis conducted by a psychiatrist with expertise in delirium. And what we found, we did several different permutations and combinations. We looked at sequential testing, simultaneous testing, and ultimately what we found was the best single test was the months of the year backwards across all the hospital patients with a sensitivity of 83% and a specificity of 90%. And then when we looked at the older cohort, we found that, again, the sensitivity and specificity were still the highest in the months of the year backwards. So we felt that this was likely to be a useful test for delirium screening. There's been several tests since then, which have all found that the sensitivity of months of the year backwards is about the 80 to 90%, and specificity ranges a bit more between 60 and 90%. However, there's very little evidence to date about the implementation of this as a screening test. All we know from another study that we conducted in 2016 looking at 5 short screening tests to detect delirium is that refusal rates were low for delirium for months of the year backwards, but this was in cross-sectional studies, so this might be higher, refusal rates might be higher with repeated testing. And in this study we looked at other cognitive screening tools such as the 6-item cognitive impairment test, which is quite a useful brief cognitive screen including temporal orientation, short-term memory, and 2 tests of attention, spatial span forwards, the clock drawing test, and the intersecting pentagons. So the months of the year backwards is also used as part of another test often. So at the moment there is researchers in Harvard and Penn State who are studying the months of the year backwards with a test of temporal orientation as a step 1 test, with an operationalized version of the CAM called the 3D CAM, which was developed by Ed Marcantonio, as a step 2. And this is currently under study, but preliminary analysis shows that the sensitivity and specificity are very high when you use both of these together, and they're testing feasibility for use in their clinical settings at present. The 4A's test, which is a European developed test, incorporates the months of the year backwards as a test of attention. It also looks at level of alertness. It also conducts a very brief cognitive test using the AMT4, which is the abbreviated mental test 4-item version, which asks the patient's age, date of birth, place, and the current year. And so this test has fantastic psychometrics, kind of very high sensitivities and specificities. And it's really been incorporated a lot in Europe for delirium screening. However, in terms of screening on a daily basis on the ward, it may not be feasible because of this need to check for collateral history. So it may actually be better as a step 2 test when using delirium screening once the patient has actually been admitted to the hospital. In Canada, there's other studies ongoing at the moment looking at the radar as a step 1 and the 4AT as a step 2. And this may work well. However, I'd have concerns if the step 2 is dependent on step 1, which it usually is in these kind of algorithms, if the radar is still only got a sensitivity of 73%. I believe, and there's more work coming out now to show that the radar may be performing more accurately. In London, what we've done is, with permission from Philippe Voyer, we've actually combined the months of the year backwards on the radar as a step 1 test. And we're currently testing the implementation of this on the acute care of the elderly unit in London Health Sciences Centre, using this as a step 1 test daily by nursing staff when patients are admitted to the ACE unit. And then, so we're currently in pilot phase, and my second step test is likely to be the 4AT. But we still have to get through the piloting phase of the step 1 part of the test, the radar and the MOTYB. And what we're measuring is inter-rater reliability, diagnostic accuracy, the duration of the test, withdrawal and refusal rates, rate of completion of each element, as well as the extent of missing and unusable data. And what we're also, obviously, one of the major things that we're interested in looking at is acceptability to patients and caregivers, as well as acceptability to nursing staff, which is really key when you're trying to implement something in the clinical setting. So this is food for thought. What do we need to be asking our patients, our caregivers, and our nursing staff to find out whether or not our tools are working? And what else do we need to be measuring to make sure that our implementation is successful? And I'd really appreciate any input from all of you to see if there's anything that I've missed. And given that a lot of you have already been implementing screening, I'd really be interested to hear your thoughts as to how you managed to do this successfully. And don't forget, before I go to questions, please don't forget to tweet and retweet with the hashtag WDAD2018 and hashtag DeliriumA, our Twitter feed at @idelirium_aware tomorrow, and to promote World Delirium Awareness Day. Thank you very much.
Thank you, Niamh, and that was the cue for the audience to ask questions. I have a number myself, but before I go with that, I know my questions would come from consolidated feedback from coaching many of the Delirium teams in the Senior Friendly Hospital Collaborative, but I imagine many of those teams are on the line, and I'm wondering if you have specific questions you'd like addressed. It's a rare treat for us to have someone with such knowledge in the research literature, but also the knowledge in implementation and the bedside practice. If I could just, while people are typing in, I can start with one question. Is for a long time, Dr. O'Regan, the CAM has been the favorite tool of many, and we know the CAM isn't without its weaknesses. With all the research that you presented and are conducting, do you think we're hitting a zenith where other tools are emerging that may be more feasible and more accurate than the CAM?
So I think the CAM will never go away. I think the CAM is an amazing test. I use the CAM daily myself. I don't think that it should be used as daily screening unless people are very, very comfortable using it and can do it quickly. And that's what the challenge here. So it's trying to figure out whether it should be used screening and diagnostically. Like, I definitely think that there are other tools emerging now that are going to be brief and can be used, along with, say, for example, the vital signs or the medication rounds, just to assess, could this patient have delirium today? Certainly what we're not trying to do is minimize the different symptoms of delirium into a very brief test. And that's what a lot of people have concerns about when we talk about these kind of brief tests, that delirium is such a nuanced, challenging condition with such complexity that if we're literally basing a diagnosis on a 2-point test, that we're going to, we're trying to distill it down to too small a measure. But what I'd say to that is that this is just the beginning of the assessment, that once somebody screens positive using this test, then they have a much more in-depth assessment, which could be the CAM, for example, to assess whether it's delirium, dementia, psychosis, akathisia, or whatever else it might be. But yeah, I mean, that's what my belief is going to be the future, is that the CAM is going to be integral, but that there's going to be newer tests that are going to be used at the point of care on a daily basis.
Excellent, thank you. And the questions are just flowing in. I'll start queuing us up. Brianne asks us a very relevant question, and our office, in fact, is very interested in this because Brianne's familiar with delirium assessment with the CAM in the hospital setting. However, in the home health setting, is there an ideal tool, and what are your thoughts on that?
So just the semantics I may not fully understand. When you say home health, do you mean the person is actually at home, or do you mean in general across the community? Like, do you mean like retirement homes as well, or long-term care, or just the person's home? Oh, just at home. Actually, I think the CAM is a good test at home. It's probably it's probably better than most other tests. The person's in their own environment. There's often a collateral historian there if you're assessing them. And so you're going to get all the tools you need really to assess them using the CAM. So I think in that situation, you're already doing a thorough assessment of the patient. And in that case, I think the CAM is perfect. So what I'd like to kind of reiterate is that if you are brought to see a patient specifically to look for certain geriatric frailty syndromes, including delirium, the CAM is a perfect test if you've been trained how to do it and you're comfortable with it. If you are a nurse on the ward or a resident that's not that familiar with delirium, or you're busy, you've got competing demands that day, you've got sick patients, but you need to do screening on everybody for delirium, then the CAM may not work, and then maybe something like the monthly or backwards or the radar might be better. So that's what I'm trying to get at. Does that make sense?
Yes. And I'm going to combine two questions. Melanie asks about delirium in patients with a psychiatric history, and Winchester District, hello Winchester, has a question about months of the year backwards, if there's practice effects of being performed regularly, if you continue asking that on a routine basis. And also related to Melanie's question, is it useful in clients with dementia, possible delirium, and adding Melanie's bit in a psychiatric history?
Yeah, so they're all really, really good questions, and this is like really speaking to the nuances. And yes, patients with dementia may very well fail the months of the year backwards, and they may screen positive, and that is a problem. And so, there is no quick solution to that. So sometimes what we have to do is screen these people positive on day one. And anyway, firstly, patients with delirium are so at high risk or patients with dementia are so at high risk of delirium that doing a proper delirium assessment on day one is not a bad idea anyway. And then you find out at that point, do they have delirium or not? If they don't and they fail the months of the year backwards, you know what their baseline is like, and then you pick something else the next day, like something simpler, like counting backwards from 20 down to 1, or counting backwards from 10 down to 1, or days of the week backwards, or something else. So these people are, obviously there's a lot of them. We have a lot of people with dementia on our wards. But some of them will be able to do the months of the year backwards. And so what we're looking for is change from day to day. And we have to pick a test that will be sensitive. However, we are going to have some false positives in dementia. So that was the question about the months of the year backwards. What was the other question? Sorry, Ken.
It was about assessing delirium, the ideal tools or approach for people with a psychiatric history.
Oh, yeah. So again, that's very challenging. And so the best evidence would be for a very detailed tool, like something like the Revised Delirium Rating Scale, where you're actually looking at a spectrum of symptoms and marking severity. So in those patients, it's very, very hard to say for definite if it's delirium or their primary psychiatric complaint. What a rule of thumb for me would be, one, if they have an acute medical illness, delirium has to be your top concern, and you'd work with the psychiatry team to manage that, given their past psychiatric diagnosis. Obviously, you need to outrule serious medical medical problems that need to be treated in order to try to address what might be causing a delirium. And then after that, if there isn't anything identified and it may be their primary psychiatric diagnosis, then you need to work with the psychiatrist on that. But again, it's a very challenging area. It's not going to be straightforward.
Just reading out Beth O'Leary's question. Now, Beth managed the team at Sunnybrook, who for more than a year took a huge magnifying glass to try to pick out sources of inaccuracy, the causes of inaccuracy in their CAM screening. I was happy to be part of that team, and I know that although these results weren't repeatable, their accuracy rates with the CAM floated from, I think, a baseline of around 40% to the end through repeated education and quality improvement cycles to about 70% accuracy in their team. And Beth points out that sometimes coding rules, administrative functions, can compromise our reporting of accurate delirium rates. Do you have any comment on that, Dr. O'Regan?
As in that we're not able to code delirium appropriately in the hospital records, is that what you mean?
I think so. Beth, could you elaborate on that? And while Beth is typing, we have other questions regarding the radar tool from Humber River. Is that only being used in Montreal?
To my knowledge, at the moment, yes, we're using it too at the moment, as I mentioned in our slides. I think it's going to be a really great tool. And getting back to Beth's question, so this is an international issue in terms of coding. It definitely does impact on appropriate, I suppose, understanding the scope of the problem. I'm not very familiar with how the codes are actually made in Ontario yet, but I do know that, number one, because it's under-detected, having it coded is a huge issue. So even just if we could get the detection rates up and then work on the coding, that would be amazing. But certainly I think coding for delirium and health record data is a big issue internationally.
Great. We have more questions floating in. In the meantime, Marilyn asks us about another challenging situation. Is it appropriate to use this delirium screening when alcohol withdrawal is present? So
alcohol withdrawal delirium, to me, is a different entity. and a lot of people in the delirium world would agree with that. It's a very specific precipitant and presents in a very specific way. We have the CWAP protocol, which you've mentioned, and I think that is the best way of monitoring a person with delirium tremens, or with a risk of delirium tremens, is the CWAP. Helpful to measure their attention too, if you like, but I think the CWAP covers the most important aspects of alcohol withdrawal.
Great. And Beth adds that our reported coding rates run around 5%, which is frustrating because we know our rates are much, much higher.
Oh, much, much higher. And we have it, like I'm from Ireland, as Ken mentioned earlier, and you can probably tell by my accent, but we've had very similar issues there. And as well, not only that, but coding of dementia is also very low in Ireland too. And this is a huge issue, because the funding for delirium is limited because of this, as well as obviously we've got this amazing Senior Friendly Hospitals program going, which is fantastic, which has been in part funded by the ministry. But in general, when we're trying to sell delirium as an issue to management, etc., when we don't have accurate rates in our hospital data, it's hugely challenging to get any traction.
Yeah, one interesting bit of feedback from the collaborative is we found that, and again, this is anecdotal evidence based on quality improvement coaching interactions, but the sites that were small, really small sites, 20, 30 bed sites in small rural communities, they felt very confident in their accuracy rates. And the main reason they felt that way is because they knew the patient really well. It was a small, tight-knit community where one knew each other. And knowing the patient background was a key part of knowing when things were off. And in fact, that was one case where, a well-equipped academic hospital didn't fare as well because we simply don't know the patient because of the volume we see.
It's just so key, just knowing the person and knowing they're off their baseline is, one of the cardinal features, and so that's it's fantastic to hear that story. I had actually heard it before, all right, because I work with Laurie McKellar, one of the nurse practitioners here, and she had been telling me this when I arrived to Canada first, and had been talking about the CAM.
Great, and Dr. Ryan chips in with family caregivers seeming to be very aware of acute changes in condition in their family members that are often signs of delirium. What's your sense, Dr. O'Regan, of the status of engaging family caregivers in the early onset of detecting delirium?
Oh, I think this is absolutely key and such a fantastic point to raise. Not only do we have to engage them in the early onset of what may become delirium, we have to engage them when the person gets delirium too. But yeah, there have been some, the single question in delirium is a family screening tool that had some good diagnostic accuracy. I think it was, I can't remember the exact, but it was above 80% sensitivity. But it's only been validated in one population until recently. And that's like asking a family member, do you think your relative is more confused now? And I think that's another way of finding out when the person comes into hospital if they could potentially have delirium. I think, the pressures nowadays on everybody to try to get all the work done in the day, we forget the importance of engaging with family members often. And it's so key they know the person the best. Like anecdote from I was on team on the acute care of the elderly unit last week, and the resident said to me, the daughter of this patient thinks she's confused, but I went to see her and she's not, she's fine. And I was like going, well, to be honest with you, I'm going to believe the daughter here. She knows her mother much better, and if there is delirium, it could very well be fluctuating and she might be fine now. So it's just even educating our trainees as well about the importance of family and how they can really help us in the diagnostic process.
Right. One of the practice changes we gravitated to was, because it is so hard to grasp the concept that a 4-question algorithm can really accurately detect such a complex thing as delirium. But we began to modify our practice with many of the teams in item 1, the acute onset and fluctuating course. Many of the teams adopted the practice of screening it as an or, acute onset or fluctuating course, as being positive. And the purpose was to try to capture more or to miss less possible cases. And then a positive CAM would then trigger multidisciplinary rounds and conversations, so you could consolidate the observations of the team to then tease out whether there was actually a delirium present.
Yeah, and actually, being honest with you, the CAM that you're describing, we call it CAM sensitive. And we do that a lot, actually, and that's how I would score the CAM, because fluctuations are actually very challenging to understand and pick up. And, you know, and also knowing the acuity is also challenging. So if you've got one or the other, I think that's reasonable diagnostic criteria. So I think that's a great way of trying to not miss delirium.
A couple questions. Melanie, this might also help with Beth's input, is if you can provide an example of some of the miscoding when delirium is diagnosed.
So I'm not sure on specifics, but because I haven't actually looked at that data myself, but from different studies and from my own experience, delirium is misunderstood as depression a lot. We get a lot of consults for patients who are depressed, but they've got a hypoactive delirium. Delirium is miscoded as dementia, obviously, and cognitive impairment too, when people don't understand that the change is acute. And they're the major kind of mistaken identities, I suppose. And I'm not clear on what the codes are actually. Maybe Beth might be able to give us a bit more information as to what codes are being used incorrectly for delirium.
Great, and I noticed Beth is typing in. We have a question from Sarah from Winchester District. Is when delirium is slowly resolving, often a longer time assessment still picks up quite a bit of inattention. So Sarah asks if you have any strategies for properly assessing patients who are in that slowly resolving phase.
To see if they're improving.
Yeah.
So what I tend to do, and I say this to family members, is that I monitor them from day to day with a cognitive screen, basically. I use the 6-item cognitive impairment test because I like it, and I've been using it for a number of years now. But you can use any cognitive test that's quick and that you don't mind doing daily and the patient will engage with. But what I say to family members is that delirium is a fluctuating condition, and these fluctuations are going to be quite frequent initially, with varying degrees of severity that are of high severity at times during the day. As the patient gets better, it's still going to fluctuate, but the fluctuations get wider. So it may be that initially, as they're beginning to resolve, that the fluctuations may be over hours. And then as they begin to resolve, they might be much better, but then it might be that they fluctuate and have a bad day or a good day. And so that's what I say to family members, to help them try to understand the course of delirium. But each individual will have a different course. It's just understanding that they're not going to get better on a very kind of upward trajectory all the time. It's going to be up and down because of the fluctuating nature. But obviously, if somebody was to get markedly worse on a particular day, you have to think of potentiating factors like could the patient, the usual, could the patient be constipated, in urinary retention, dehydrated, etc. But I don't have any specific tools, so I think it would be what you're comfortable using to monitor cognition and behavior, basically.
It's a real encyclopedia of knowledge you're sharing. I noticed a few more people typing. We have about a minute or two left as we head into the wrap-up. Please continue typing your questions. There is a couple minutes left, and we can answer any last thoughts, because it's a very special opportunity to have someone with such expertise. Oh, here's one from RGPT, recoding. This must be Beth's team. Delirium, even when documented in the progress notes, often does not meet the criteria for significance required by CIHI. That's our Canadian Institutes of Health Information, for coding of hospital charts for the discharge data. That's a database.
Okay.
The chart and use the chart abstraction tool by Inui.
Oh, yes, yeah.
You will capture many more cases of delirium. Those are the keywords you look for delirium in the charting than if you ask health data records to pull charts. So again, another tool in abstracting charts. That is a very laborious procedure, if I understand.
Oh, yeah. No, that's a huge issue. So even if delirium is actually documented in the chart, it doesn't meet the criteria to be coded. That's a huge problem, and it's something we're going to have to try to address. If delirium is mentioned, it's a diagnosis, and it should be actually written in the coding. I did not know that.
Nope.
Thanks for
and that was
sharing
Dr. Barbara Liu, our Executive Director. Another question I do want you to address from Heather, for those working in the community, seeing clients post-hospital delirium, and I imagine this happens more often than we'd wish, what time frame would you recommend for follow-up assessment?
Sorry, could you just repeat the question there? Just time frame for follow-up of delirium when?
Or post-discharge, clients who've been discharged from hospital being seen in the community by a provider, what time frame for follow-up assessment do you recommend?
And do you mean by a family practitioner, kind of a community health physician, not or a community health team, rather than coming back to a clinic? Is that right?
Yeah, Heather, could you elaborate on your question?
I mean, I can answer both anyway while we're waiting. So I think somebody with delirium should be followed up within, if they have unresolved delirium, it should be within the next few days, really, if possible.
I would think as early as often as possible.
Yeah. If they have
resolved. Diane loves this information. She supervises many personal support workers on a daily basis, and they, along with family members, are often the first to notice sudden or fluctuating changes. They can help to liaise with family doctors. This is wonderful. Often the people that are closest to the patients, not necessarily those that have, the most certificates and degrees, are the people that know when changes are happening. So absolutely. Diane mentions having a tool to bring forward is something she'll explore, and perhaps the CAM be used that way as a flagging tool for PSWs to report to health providers. And Diane, I love that idea.
Yeah, no, it's great. And there are actually, if they wanted to involve the family members, there is a family version of the CAM that could be used.
So the FAM-CAM, and perhaps we can dig that up and share that with you, Diane, if that would be helpful. If we have rolled over the hour, there's a few other questions typing we'll keep an eye on. In the meantime, I'll just roll this to a close. You'll receive an email with an evaluation, and that'll contain the slides and recording. Our office is in the midst of planning more webinars for you in the spring or summer. Stay tuned. We will email you with that information, and hopefully they will be appropriate to sandals and short sleeve shirts. I think there's, Heather, one more question. For treated delirium, what's the average time it takes to resolve? And that would be in the community. Yeah,
I mean, I actually don't know the exact date on that, but I would think that you would want the people who so it's treated delirium, you're saying, though. That means it's already resolved. So then follow-up should be whatever is most appropriate, for their other healthcare concerns, and potentially at least within 3 months, I would think myself. That's just off the cuff. If it's not resolved, then I think you need to try and see them very quickly.
Yeah, I would imagine that answer fluctuates widely from patient to patient.
Yeah, like delirium.
Screen early and often, and really get to know your patient, know their baseline, so you have a good sense if something's off. I think we've gone a little bit past the hour, but thank you, everyone, for this gorgeous amount of attention. Thank you to Dr. Niamh O'Regan. It's rare for us to be able to speak to someone with such expertise, and also having the practical experience of applying the tools and developing new tweaks on tools. On behalf of the RGP of Toronto, this has been a blast. Thank you. Have a wonderful afternoon, and thank you for your attention and for all your comments today.
Thanks very much, Ken. And don't forget World Delirium Awareness Day.
I'll go back to the hashtag. Thanks, everyone. We're signing off now. It's been a blast.